Welcome everybody to the Wednesday morning session of the Connections Conference. I'm glad to see some faces and names of people that have attended in the past. And if it's your first time attending, welcome. So I think at this point, I'm going to be turning it over to Christy to introduce our presenters for today.
Thank you so much, Laura. So welcome everyone to the third day of our Connections Conference. This session is Brain Injury and Opioid Use Disorder, Understanding the Connection for Better Treatment Outcomes. And I have the honor of introducing our presenters today. Carrie Collins-Fadell is the Director of the Brain Injury Alliance of Arizona. She oversees the State Opioid Response Peer Support Team at the Alliance. The team works to assist survivors of brain injury in navigating through substance use, misuse, and addiction with an end goal of living well after brain injury. So welcome, Carrie.
Well, thank you. I'm Carrie. I'm with the Brain Injury Alliance of Arizona. We're so thrilled to be here today to talk about the work that we've been able to do over the last 18 months around addiction and brain injury, particularly the SUD and OUD. So thank you for having us. As we're all very busy, in the last year and a half has been so complicated, we always like to start any presentation with a little reminder that self-care doesn't have to be complicated or even expensive. So if you've never heard of, let us introduce you really quickly to the 4-7-8 breathing. You can do this, you can set a reminder to do this at the top of the hour if you're sitting all day or if you're in your car driving. It's always a great time to do that. So it's in for 4, hold that breath for the count of 7 seconds, and then a big exhale for 8 seconds, and it feels great. I always used to tell people you'll be the calmest person going 10 miles an hour on the 10 if you remember to do this anytime you're stuck in traffic. We also have square breathing. Usually, you ever see anybody and they do it and they count it out like this? That's breathe in for 4 seconds, hold for 4 seconds, exhale for 4 more seconds, and then hold for another 4. So that's 4, 4, 4, 4. That's the square breathing. Just a reminder to always start a new venture like this being mindful and in the right space. I am joined today by Janice Podzimic and Liz Bradley. These are two members of the team who work actually boots on the ground administering some of the things that we're going to talk about. Janice and Liz, are you able to introduce yourselves?
Yes, I am. I'm Janice Podzimic, the interpersonal violence liaison with the Brain Injury Alliance, and also a certified brain injury specialist, and member of the State Opioid Response Team. Sorry, Liz.
And I'm Liz Bradley. I'm also on the State Opioid Response Team. I'm our brain injury and addiction specialist, and I work with our families as well.
Thank you so much. Liz runs along with the neuropsych, runs a wonderful support group for families that has a real addiction specialty to it. So we're not going to talk a lot about, let me just kind of set up what we do, and it kind of gives you a little taste of why brain injury is complicated, and then we're going to go right into causes of brain injury, and then how it relates to vulnerable populations and that substance use disorder. Janice, Liz, and I have presented a lot over Zoom the last year. We're very informal. Feel free to ask questions and engage us if there's anything that you want to share. Oh, somebody says, beautiful picture. This is a volunteer and one of our survivors who attends Camp Can Do. We have one of the only camps for adult survivors of brain injury in North America. There's another one in Toronto, and there's a day camp in New Jersey. So we were very proud of that. It'll be back next year. So Brain Injury Alliance, how did we get here? What work are we doing? We were founded in 1983 by parents in Tucson. They really wanted information and support for their adult children who had been formerly independent, and then through accident, illness, or injury, all of a sudden were back at home and needed a lifetime of care and support. So they really wanted to come together to look at who are medical providers who understand brain injury. And in 1983, that was an uphill task to find specialists. We provide a lot of training, support. Our services are free to family members. We don't charge people. And this is important. We serve people who self-identify as having a brain injury. Maybe they just have questions about small brain injuries that have added up. Maybe they never had an ambulance ride and a diagnosis for a brain injury, and they always wonder. And that can be exceptionally common. I found that my own mother, after I had worked for Brain Injury Alliance for a couple of years, she said, you know, when I was a child, I was riding my bike with the big musical instrument to school and fell over the handlebars and was unconscious for half a day. And she would never identify that as brain injury, but we know loss of consciousness can be one of those keys. So we will, there's really not a bad referral for us. We'll get somebody to where they need to go if we're not the place. And we provide services at all points of brain injury. So we could be working with a family while someone's in a coma in the hospital. Even we start working with the family to get them prepared for the next steps, the next treatments, all the way to somebody that maybe had a brain injury 40 years ago. Our existing, before we were able to partner with Mercy Care, we had an existing team and a state contract to really provide services for those who are in hospitals in those acute and post-acute settings. We did formal referrals from them, and we actually, oh gosh, this is so sad. In the middle here, we had actually worked up to having a QR code to try to get those concussions, working with Foothills Sports Medicine clinics. We had to pause this due to COVID because our team was overwhelmed with those post-COVID strokes, those COVID survivor neurological complications. But we do also work with professionals to help them understand the variety of things that can happen. So if there's any providers who are on here today listening, we would love to partner with you and have referrals from you. We do have advocate and peer support training as well. I will put in a plug for that. That's happening next week. And we'll have another one probably in August. That really is that's a half-day training that kind of really gives you a flavor of how we can work together for those really good goals for your clients. So let's talk about how we were able to grow and the work that we're able to do thanks to our partnership with Mercy Care. We were one of the first states, gosh, I don't know, I haven't been able to find anyone else that's doing this work in this way other than us through our partnership with Mercy Care, but we were able to really deploy an opioid response team in the community to look at 3 specialized populations: families, veterans, and also those who had a brain injury through violence, interpersonal violence. And everyone on our team that works with clients is either a certified brain injury specialist or certified recovery support specialist. So we're here to talk about brain injury. That's a little bit about us. What do you think of if you were to have a client or if you were to have a family member tell you, I think I have a brain injury, or I've been told I have a brain injury? What comes to mind? Feel free to put anything in chat. Loss of memory, memory issues, confusion. Angela says cognitive delay. Ooh. Rebecca says personality changes. What do we think? Can a brain injury change who you are? All right, let's look at the technical definition. It's an injury to the brain that occurs after birth. So before that, it's going to be congenital, and it's also not degenerative. So we would consider Alzheimer's disease, dementia as a degenerative disease process. That would be, we would differentiate that from brain injury. I worked for a number of years for Alzheimer's Association, so I am aware that there's a lot of similarities in how the plaques and tangles disrupt neurocommunication. But a brain injury results in the change of the brain's neuronal activity. So you have all these neurons. If the neurons get damaged, there's also a chemical process which damages the tissue around it. And then it changes how the person perceives the environment, how the person interacts with the environment. It can sometimes temporarily or permanently change who you are. So how are people getting brain injuries? So if it happens after birth, it's an acquired brain injury. Acquired brain injury can be both non-traumatic and traumatic. We always like to test, is this kind of new information for you? If you look at that left side of the column, would you have thought of a tumor or chemical exposure near drowning? Was that kind of in your vocabulary as a brain injury? when I started 6 years ago, it was really not even fairly well understood that a concussion, that mild traumatic brain injury, was a brain injury. And there's been a lot of really exciting growth and understanding around sports concussions. But I think something that Janice and Liz found when they are out in the community, it's not so much so in those anoxic and hypoxic injuries. Do you ladies want to talk about that, about strangulation and overdose?
Yes, in the domestic violence, interpersonal, intimate personal violence sector, the strangulation is something that some have spoken about just in passing and not relating that to a brain injury. So instead of saying choking, which is if something's lodged in your throat, strangulation is, of course, the use of someone strangling someone and possibly losing consciousness.
Yeah, and likewise with an opioid overdose, it's not something that you generally think of as causing a brain injury, but it is that lack of oxygen to the brain. What an opioid overdose does is slows down breathing or even stops it. So you're not getting enough oxygen to the brain, which can result in either an anoxic injury, which is no oxygen to the brain, or a hypoxic, which is not enough. And that can happen within 3 to 5 minutes of someone having an opioid overdose, which is why I always encourage everyone to carry naloxone, because time is of the essence.
And Liz, is it true that if you're having an overdose, there's both non-traumatic and traumatic brain injury risks?
Right, so you could have that that lack of oxygen, and you could also, if you are standing or sitting, you may, if you pass out, fall, hit your head on something, and so now, double whammy there. So there's quite a few different dangers.
If anyone is familiar with Phoenix News anchor Brandon Lee, he talks about, he's very honest and open about his addiction issues. He wrote a book about it. In fact, he actually had an overdose when he was in California and fell forward through a glass table and actually needed brain surgery. It was so serious. Mm-hmm. So that is when we are seeing people who have numerous overdose reversals, we wonder if they are getting the information they need. Are they the people that say they feel different after the overdose and just can't put their finger on it? And Janice, you've done this work for about 20 years. You started in Minnesota doing screening at the Tubman shelter. It seems like there's been some advancements in law enforcement or first responder understanding about brain injury. They're asking different questions, even like, were you strangled to the point where you lost consciousness or were incontinent? So that way they can really kind of get to this, but it's not making its way into people's medical charts.
Yes, I was part of a committee that worked along with the Tubman shelters to coordinate certain questions that should be asked either upon intake or when those individuals are actually ready to speak about what happened to them. Instead of, it's called the HELPS tool. So, and each letter coordinates to a certain situation. So if instead of asking, did you get knocked out or did you fall or whatever, it's have you ever hit your head or has your head ever been hit? Have you ever been strangled? Have you lost consciousness? Have you received an injury that you did not go to the emergency room for? So there were certain questions that we worked out to provide for this tool, and it's being used nationally now.
When you look at the causes, falls is number one up there. Motor vehicles has slipped down a little bit. Cars are being made safer, but also people are surviving motor vehicle accidents with brain injury that would have been fatal, and they are going to present in our community and need our help and support. Blast exposures, this can be complicated for those who are veterans. They might not understand because there wasn't a penetrating skull wound that anything like those IEDs are going to affect any organ that's in liquid, especially your brain. It could be your brain as well. Okay, so when we look at brain injury, the CDC and a lot of things only track traumatic brain injury. So we don't even have data. Like Liz, do you even have data on non-traumatic brain injuries? No. So we're really in a data desert when it comes to brain injury. We know surveillance on TBIs if you are admitted to a trauma one. So think of how common it would be to have a concussion and go to a local provider, or stuff from the VA, tribal, and pediatric stuff, I believe still does not feed up into CDC. But when we look at reported causes of brain injury that are tracked, these are what we're seeing. So some of these, even though people can have risk factors for brain injury, we're just seeing those actual everyday things. So when you look at special populations like veterans, think of it, they have all of these duty-related causes of brain injury, and they have everything that you and I have just in the normal course of our day. Sports and recreation, those little brain injuries, again, can add up. When we look at the impact and how it's going to impact us getting help with different medical and human services and interacting with our family and maintaining our place in our family, it's really going to be how it plays out in your life is location, location, location. A lot like real estate. So your brain is the CEO. It's responsible for everything you do, even those things that you don't even think of and you take for granted. We're definitely seeing this with COVID. People having like brain stem, these things that are impacted that they never even thought of. Oh my gosh, your brain does that. Like regulating your blood pressure. I actually have a family member who experienced this. No previous history of brain injury. When he stands up now, has trouble regulating his blood pressure. He is better now, but can you think of how difficult it even would be to get through a day of work if every time you stood up, you had to take time to reorientate yourself?
And when we're looking at domestic violence, the frontal lobe area is the area that is generally more impacted during those situations. So you see, utilizing the frontal lobe where our initiation, our awareness, and being able to plan can be greatly impaired.
I'd also like to point out an interesting thing that I was really shocked to learn is no matter where the impact is, a lot of times the frontal lobe will be affected regardless because of the bone structure in your skull near the eye sockets. There are protrusions of bone that, if the brain is jiggling around in there at all, are likely going to make contact with that frontal lobe. So that's affecting your decision making, your planning, your you might have a shorter fuse, things like that, that can then contribute to more brain injuries or some of the other special populations that we'll get into.
And imagine too, if you have a teenager who their personality is developing, their skill set is developing, and they have a frontal lobe injury. When we do some trainings, we actually have people stand up and read that frontal lobe deficit list that could emerge. And we say, okay, is that the job description of a teenager to test limitations, to be disorganized, or is that an impact of brain injury?
Yeah, and the frontal lobe is the last part of the brain to develop. It doesn't really get fully developed until around 25. And so if you even have an adult with a frontal lobe injury, they might start acting more like a teenager.
It can be hard too to unravel that mystery of brain injury. If you look at your occipital lobe or your vision is, sometimes I had this happen to a friend actually. She had a brain tumor and she was having vision trouble. So she went to her doctor and her doctor said, well, you have great vision, for someone your age, everything's good. Well, it was really what the eyes were seeing had to travel all the way through to the back of the brain to get interpreted in different ways. And so that's where really you do need somebody that can help you through a variety of specialists.
It looks like we actually have a question in the chat box. It was asked by Dorothy Thomas, would it be good to have a psychoneurological evaluation if there is a psych or physical barrier to the brain injury? And how can a person have it covered under access to get this assessment done?
Right to the good stuff.
Yeah.
We're going to cover all that in a second. And the answer is it can be complicated. That's why, in addition to this team, we actually have a core team that looks at providers for insurance and who has availability, who you can get to, who's doing telehealth. Make sure that you get to the right appointment. If you're doing a Social Security disability evaluation, making sure that they don't schedule you for a 20-minute, that you need. So we have an entire team behind Liz and Janice that also works with this with those issues as well. So there are definitely a lot of times a neuropsych eval would be good, and there are some times where things aren't going to show up. Janice, did you want to add anything to that? Or we'll cover it.
No, I just wanted to say that's a very good question.
Yeah, I like how you're
right off the bat.
You guys are all in the front of the class here today. So what happens? We talked about that location, what can happen. Look at all the varieties. Oh my goodness. Think of how different this is than just having like a broken arm or you have a cast. You know that on, Tuesday in July, you're going to get the cast off and go back to normal. All these different emotional, somatic, cognitive. So what does a brain injury look like? No joke. If we were at a brain injury conference, it would be a race to say, if you've seen one brain injury, you've seen one brain injury, because the symptoms can present so differently. And we're seeing this play out with COVID. I mean, the COVID, I was actually in a meeting before this. They're trying to figure out what codes people are using for their neurological issues from COVID, just so that they can get a handle on how many people are having it. They're between B94.8. No, I'm just kidding. No, but they are. We're really trying to get everyone just to use the same code so that we can start tracking it. Emotional, lack of motivation, depression, sadness. Liz, did you have some suicide statistics that you wanted to share?
Sure, let me pull that up real quick. So unfortunately, people with a mild TBI, like a concussion, are about 3 times higher suicide risk rates than the normal population. This can be associated with this can be due to associated risk factors like psychiatric conditions and psychosocial disadvantages that you have after a brain injury. If you have a traumatic brain injury and not mild traumatic brain injury, your rates are 4 times as high. And this can be because of those factors, plus you also may have physical, psychological, and social consequences stemming from those injuries. So it's 3 times as high for mild, 4 times as high for normal TBI. If you add substance use disorder into that mix, mild TBI plus substance use disorder, 5 times as high as the average population. And TBI plus substance use disorder is almost 7.5 times higher than your general population. It's a lot.
That can actually be, if you're not going to be able to be in someone's medical records, you might even say multiple suicide attempts could be a sign that there might be something going on with a brain injury.
Mm-hmm.
Even just looking at the first one, poor concentration, memory problems. Can you imagine trying to go to a 12-step meeting or trying to navigate the healthcare system if those are some of the things that you're seeing? Poor balance, which makes you more at risk for future falls. Seizures is huge.
And not being able to follow the program is an issue that those that survivors of brain injury would be facing.
Yeah, there's a large percentage, I think it's somewhere between 30 and 60 people seeking substance use recovery services do screen positive for a lifetime history of brain injury, whether they knew that or not before walking in. And sometimes at those recovery services, they might seem like they're not engaged. They might seem like they don't want it enough, that they're not trying hard enough. But that can be a result of the kind of just the results of the brain injury, that they may look disinterested or they look like they're not trying, but they really are. They're just having those deficits.
So from that list we saw before, you can see where it really starts to disrupt our relationships, disrupt your ability to support yourself, maintain employment, problems with learning. And Janice, you had a great example that you've used. This can also disrupt someone's ability to access higher education, which can then lead to them being more destabilized in potentially violent relationships.
Mm-hmm. Well, and what is it, 31 to 67% of women accessing substance use disorder treatment reported having domestic violence in their lifetime in the past year. So it's imperative that they seek some sort of treatment, but not being able to have the wherewithal to actually make those decisions is quite imperative.
Also, only about 40% of traumatic and non-traumatic acquired brain injury survivors are able to return to work in the first 2 years.
Oh yeah, recovery can be a really long process, and that's hard on families. No one envisions a world where maybe the breadwinner who carried the insurance is then not going to be able to dress themselves or require 24-hour care. And the acceleration into it can be 0 to 60. I mean, we have clients where life was good, they were in law school, and then by Thursday of that week, they are picking someone up from the hospital who fully needs their care. And so you start to see people get destabilized very fast. Lots of different things can really determine your healing timeline, stress for caregivers and stress for your families. A brain injury can turn the volume up on all the things that we have as people. If you're predisposed to anxiety or depression, oh my goodness, it can turn the volume up on that. There can be an injury cascade where maybe I've seen this in a couple of people who had overdosed. They woke up and didn't have vision problems, but as the brain adjusted and rewired after the overdose, they had vision issues. So it feels like sometimes you get a handle on one thing and something else emerges. I also just wanted to say we're talking about brain injury as a wide variety of effects. So if you we're talking about the more serious here, so I don't want you to worry. But age is also a huge thing. A lot of people think that children will grow out of their brain injury. They actually grow into it, because you can have someone injured when they don't even have that skill set or that part of their brain developed yet. Fire Captain Phil Werr from the Phoenix Fire Department has a perfect story about this. His son was 4 and slammed his head into a concrete slide on the playground. He had a concussion. They went and sought medical care. They were discharged from medical care, said that he was, his child was thankfully going to be fine. About 10 years down the road, he came to his dad and mom and said, I think I need glasses. Words kind of float away and get fuzzy after I read for a while. Well, we got him to a neuro-ophthalmologist, and it was the 4th cranial nerve or something that had been damaged, but really nobody could tell at 4. So we see this a lot with kiddos that maybe even go and have a diagnosis of brain injury. That brain injury diagnosis kind of fades away in future visits, and it starts to get labeled as things like autism, behavioral health. Janice, would you like anything that you would like to add around this?
Well, I was just wanted to share that I also had a child who was injured at 4, who had a concussion due to being hit by a train of shopping carts that she didn't see, and was not diagnosed with a brain injury. She was diagnosed with bipolar and other issues. Now, at 4 years of age, we weren't aware that there was actually a brain injury, and that was before I started working at the Brain Injury Alliance. So upon learning more about its brain injuries and seeing how she's struggled through school and struggled, still somewhat struggling, but she is a healthy 27-year-old today, but still has some struggles. And I noticed that in the chat, Laura Casper had shared about a baby being dropped at 5 months and needing stitches near the eye. How likely would a brain injury be overlooked in 1960? And how would that impact the child growing into adulthood? Now, 1960, there was probably hardly anything in the news as far as brain injury diagnosis. So, and how that would impact a child growing into adulthood, many different ways. But to get more information regarding that, I would say reach out to our resource facilitation program, and they could assist you with whatever it is you're noticing and what questions you may have.
We have another thing in the chat. Mary says her son has a Chiari malformation and is asking if that would be considered a brain injury as well. It affected the cerebellum and the brainstem. I believe we have had some clients with Chiari malformation. Is that right, Carrie?
Yeah, that would be more of a Brittany and Will question. We have our
Yeah. I know we have had some. We have our unmasking project where we have clients and others decorate a mask that represents their brain injury, how they feel about it. We also have family members do it, and I know we've seen some Chiari malformation survivors make some masks. So, but definitely, if you want to give a call to our helpline, we've got Brittany and Will, and they'll definitely be able to answer your questions there.
And Carrie, we did have another question come into a private chat. How about someone that had may overdosed on illegal drugs? Can they have a brain injury as well?
Yes, absolutely, especially if it is opioids, because it cuts off the oxygen to the brain, or at least reduces it to the point where the brain is starved of oxygen, and it can definitely kind of have a very global effect. So you're kind of not, you don't know what you might get when you come out of that. We're, super happy that that person survived, but they may not know that they survived and now have a brain injury. They might continue going through life not knowing why things are a little different. And that's definitely something that I'm passionate about. And if you have any questions, definitely reach out to me.
I think there's all these related causes too. Like when we were starting this project, I had two people I personally knew that had died from violence from their dealer. They had gotten, kind of went through the whole thing where they were prescribed medication, then couldn't get what they wanted, so went into illegal drugs, and they died from a head injury from their dealer. So there's all these different. And with the overdose, Liz, too, I think we have location on here is healing determined by. It can be, those brain injuries can be harder for the family because it's more of a global brain injury. It's not your frontal lobe, here's a list of deficits. It can be more of a global. Your brain cannot store oxygen the way we can store calories or other things. So the kind of the effects start to be immediate. Brain injury is the leading cause of death and disability in children 0 to 5. We're hoping to, at this time, we're not really scaled up to do a lot of pediatric stuff. And we're also, I just want to say, if you're here joining us from Arizona, we're in a time, remember that OCEAN team was dismantled in 2008 and First Things First was formed. So we used to have a team that really took people that had been admitted to Trauma 1 at Phoenix Children's, or they were PEDS patients, and then really looked at how they successfully went back to school. That was dismantled by the state around 2008, I believe. It was before my time. I think I was living in New York at that time. But we also have lost a lot of the TBI knowledge in our schools. Mesa schools used to have a TBI team that we worked with. They would identify the kiddos that came in, not just the sports concussions, which I think we do a much better job of, but those kiddos that had the car accident, that fell off their bike, that just had those things happen on the weekend, and then you start to see the A and B student slide into the C and D student, and we don't know why. So anything else on kiddos before we leave that?
Just also the kiddos that unfortunately have abuse in the home, kids that might have been removed, things like that. If they've had to be removed, if they're in foster care, those are good signs that you might want to look out for possible brain injury effects.
We hear a lot about trauma-informed, but sometimes the things that would have led to trauma, like abuse, would have led to a brain injury. And sometimes the kiddos need different things to be successful. That structure, a highly structured home is going to be helpful, lots of organization. In fact, we see sometimes when kiddos go to college and maybe their parents had a very structured home that helped them really not see the impact of some concussions or other things. And then what happens when you get dropped off at the dorm rooms at ASU? What happens to that structure? Holy moly, it's immediately gone. A lot of our work we can sum up with not all disabilities are visible. So we're talking about people that have every right and need to an accommodation, just as if they were using something that you could visibly see to accommodate something they have going on. One of our clients, Billy, he really personifies this. He is amazing. He looks like he could compete in like some tough man contest, but he really has trouble walking across a room without a cane. And so he has a great story. He stopped to pick up some pizza in Tempe because his family was hungry, and you have all the responsibilities usually the day after your brain injury as you do the day before. He left his cane in his car and put his placard up and parked in disability accessible parking. He had a couple of Tempe firefighters come up to him and say, "Why are you using this? You look just fine." And so he got this so much that one of the workarounds we and his doctor suggested was actually carrying a little iPad where he can kind of give people an on-the-spot tutorial. And I'll tell you, this is Billy's accident scene, and this is how his hip looks. As we started our opioid work with Mercy Care, we really liked to, it helped us to be informed that those things existed for a reason. Some of our clients that have had catastrophic injuries, you'll tell them, ask them how they feel, ask them what their pain level is. They'll say, my head feels like it's in a vice. Well, if you're living with a bullet fragments in your brain, your head is going to feel like it's in a vice. That's what Billy's hip looks like. So it's not just, not everyone, we like to really bring the message, not everyone can do yoga and essential oils and some meditation and feel great, that these drugs do exist for a reason. When we talk about accommodations, a lot of the accommodations for brain injury, gosh darn it, they are not rocket science. When we work with a veterans court, it's providing things in writing. We have people that live independently, but they really need something sitting on their nightstand or their kitchen table that they can look at and see, this is what I did yesterday. And it's really can be even like asking questions in the right way. Not if you give people 5 things they have to do before they come back to the next session of veterans court, don't just ask them, do you understand? Because what are they going to do? They're going to nod because that's how they get through the day. Ask them, what do you have to do? What do you have to bring? What tests do you have to get? Really, so it's even just asking those questions. You can't just put veterans on the door and think that that's an accommodation.
From my many years of working with people with brain injuries, some of the stories that they would tell is that they have Post-it notes up everywhere in their house to remind them to get dressed, remind them to brush their teeth, remind them to put on clothes, remind them to shut off the stove or close the refrigerator or put dishes away. So just things like that helped them to remember to do the everyday things that we take for granted.
We did a video in Billy's house, and he had a poster that said on the dog food bin that said, feed the dog 1 p.m. and then an alarm set on his phone. So there can be challenges to success with treatment. And we definitely would like to work with you more on this communication styles. As Liz mentioned, sometimes our peeps are the ones that look like they don't want to be there and they need it more than anyone. We like to strategize with people for success. One huge, and part of that can even be people knowing their deficits. So if you get housed after you've been homeless, but maybe you don't know that you can't successfully cook in your kitchen without a catastrophe, we like to be able to help people be aware of their deficits. Our Veterans Navigator helps people, someone might get an iPad from the DIVBIC, the Department of Defense Brain Injury Center, but they don't know how to turn their iPad on. They don't know how to read their cable bill. They don't know how to plan for the one-time cable installation fee. So there can be lots of barriers, whether they're in a treatment program or in the community. We like to be able to help triage those when we're working with an organization. Brain injury can get missed. Lots of misunderstanding by the person who might have had a brain injury, complex trauma. This is Ann Zaccardi. She has a TED Talk called How My Brain Injury Made Me Smarter. This is not from her original brain injury that led her to be a TED Talk talker. She actually fell, face planted while she was jogging, knew she had a concussion again because she knew what that felt like, went to her doctor in Vermont, and her doctor said, you don't have a brain injury. I'm worried about your nose. Let's get something on that. So there can be a real lack of understanding by the medical community. Real quick, we're going to talk about COVID. I think have alluded to, COVID can absolutely cause a brain injury that can absolutely be seen even on a biomarker blood test. This is from Cognitive FX in Utah. You see no head injury rates at 0, TBI at 2, and COVID-19 with no TBI history is right up there. People can start to get destabilized. We were just funded by the state to do some COVID education. Liz maintains a COVID website you can also go to. Absolutely, people can have a brain injury from COVID. Not everyone will. And children can develop neurological symptoms as well. I think at the beginning, we all kind of thought, oh gosh, maybe COVID maybe COVID won't be away. There were some positives during COVID. We have the ability to work remotely, use of telehealth. Janice does a lot with counselors with her population, and oh my goodness, telehealth has opened up just a whole new world of fun. We've also seen, though, an increase in family violence. We've seen an increase in domestic violence deaths. So that's told us that there's also an increase in brain injury from domestic violence. Liz was able to issue an opioid reduced tolerance alert if people were not able to obtain their regular amounts or regular supply. We were worried about brain injury. That kind of leads us to talking about overdose and brain injury. You want to talk about the cause and effect?
Yeah, I think I touched on it a bit earlier because I'm passionate about it and I wanted to get to it. But yes, opioid use disorder can ultimately result in overdose, maybe several. And it's that lack of oxygen reaching the brain, either none or not enough. And if you aren't found quickly enough, and if there isn't naloxone on hand to reverse that overdose, the longer that you go without sufficient oxygen, the more likely you are to come out of it with a brain injury. And again, it can be very diffuse. It can be very global, and anywhere in the brain could be affected. We can't really guess. So it's important that everyone carry naloxone if they if they can. And I want to real quick say that substance use in general increases our risk of car accidents, falls, being in violent situations. So, you know, your risk there goes up just using substances in general. You've all probably heard of fentanyl. It's a very potent opioid drug that is being both taken on purpose by people who use illicit drugs if they have a very high tolerance, and it's also being mixed into other drugs, including non-opioid drugs. So someone who thinks that they're only on methamphetamine might also be taking fentanyl mixed in there, and it's such a tiny amount makes a difference. So since there's no quality assurance, if the mix isn't mixed well enough, you might get an extra grain and then it's all over. So we're working with both people who are prescribed opioids, but we're also concerned about the people using illicit drugs, making sure that they're practicing harm reduction and that they know where to find recovery services if they want them. And then here, people who are prescribed, 70 to 80% of hospitalized patients are discharged with an opioid prescription. People with a brain injury, sometimes they do have that intense pain and they may need those opioid drugs, but they may also not have the cognitive abilities, especially directly after their injury, to manage that, taking the medications, taking only the amount that they should, that's prescribed, not accidentally taking it twice because they forgot they already took it. And they may end up developing an opioid use disorder. If they end up, losing their prescription, they may go on to purchase drugs from the street, which again can have all sorts of things in it, and it just spirals downward from there. So we also want to reach out to people that are currently in the hospital that are going to be just discharged with an opioid prescription, make sure that they have the resources that they need to manage that prescription properly so that they don't develop a dependence or an addiction to the drug. And again, naloxone, all sorts of tools that we've got that we're working on helping those people as well.
A question came in from George Gallagher for you, Liz. Cartel making boatloads of fentanyl. Is there greater incidence of OD?
Yes, there is. Yeah, it's in everything. I had a client who went to the hospital for pain that he was having, and he was hoping to get a legal prescription for his pain, and he was denied because they found opioids in his system. He uses methamphetamine. He does not intentionally use opioids, but they're putting fentanyl in everything. And I worry every day for all the people I know who use illicit drugs. There are counterfeit Percocets, Perc 30s or blues, and those are just fentanyl. Those are, people at this point know that if they want fentanyl, because their tolerance level is so high that they need higher and higher amounts of opioid or higher effectiveness of opioid to get what they need to not feel sick. And that's the thing. People may start on opioids illicitly because it feels good. Some of those people have trauma, pain. Some people might just be having fun. But if you use for a certain amount of time, depending on your physiology and other factors, if you become addicted to opioids, the withdrawals are extremely painful, extremely unpleasant. You feel sick. So at a certain point, now they're just taking it to not feel that horrible pain. And so MAT medications can help with this. We try to make sure people know that those are available, like buprenorphine and methadone. But yeah, a lot of people out there are just trying to get well so that they don't have to feel that sick.
Another question for you. How do I, as an RN, get naloxone to keep with me for visits to my members?
You can get that from pharmacy. You can also, the largest harm reduction organization in the state is Sonoran Prevention Works, and I can put their web address in the chat in a moment. Sonoran Prevention Works provides naloxone. You can also get it from the health department. I believe they now have the nasal spray. So a lot of the cheaper way to do it is injectable naloxone, but that I think kind of causes some hesitation from people to use it. Like someone who doesn't use drugs and they come across someone who is overdosing might hesitate to use a syringe on anyone. Now there is also a nasal spray version, but it is more expensive. But I believe you can get that from the health department now. I can try to find that information and put that in the chat as well. But pharmacy too.
And another question came in, can they get addicted to the cure to help with fentanyl addiction?
The cure, probably referring to MAT medications, medication-assisted treatment. So that would be methadone or buprenorphine or naltrexone. Some people say that you're just switching one drug for another, one addiction for another. With methadone, you have to take it most of the time. You have to take it in office with a prescriber or with your clinician, and you're observed taking it so that they know what your dosage is. And that basically keeps them from getting sick, from feeling those awful withdrawal symptoms. But it's meant to be used in tandem with other therapy and other treatment. You're not just supposed to be on methadone forever. The buprenorphine is only a partial opioid agonist, so there's a cap on that. So they can take that home, and usually that's the Suboxone where you put it in your cheek or under your tongue, a little strip film. And that, you can't get high off that. There's a cap on it. It only goes to a certain point where you're just not getting sick, and that's why they're able to take it home. And then again, you're supposed to be using it in conjunction with therapy, with other treatment. So it's not meant to be from one addiction to another. It's meant to maintain a person while they're in treatment so that they can eventually wean off safely, so they're not having those horrible withdrawal symptoms while they're trying to recover from whatever happened that kind of got them there in the first place, which is likely like trauma of some sort, adverse childhood experiences, and possibly brain injury.
Liz has a lot of resources too. Can you put your SUD webpage? She maintains an SUD webpage, really good resources for professional downloadables, posters, really helps get to the root cause of someone who doesn't feel the same after brain injury. When we work with, and when we are able to do a pilot or have a partnership with someone, we ask that they encourage people who identify as having a brain injury or are screened to support groups. We run support groups, psychoeducation. So that's brain health education, cognitive behavioral therapy, stress management, repeat, really helping people understand. And just a reminder, if you are a provider, someone who has a brain injury, a TBI, one, you might not even know it. So it's really good to implement an entire protocol of screening and specialized adaptions to really help people be successful. But when we are working with someone that has a brain injury, we ask providers to provide direct feedback regarding inappropriate behavior. They might not know. You don't put your shoes on the table, or and there's also things you can do, like some people have end of the day, cognitive fatigue. So if you have them do their chores in the beginning, Janice is doing a lot of work with interpersonal violence and really helping people not destabilize to the point where they need to go to a shelter, because, oh my goodness, is there any environment where someone is less with a brain injury is less prone for success than when they're out of their routine, away from their supports, maybe not getting the appropriate amount of sleep. Real quickly, I'll mention that brain injury is going to present more often in special populations, such as those that have served. We like to differentiate between TBI and PTSD, homelessness and brain injury. Sadly, a lot of the statistics have bared out that the first incident of TBI usually happened before they were homeless, meaning that that was the event that destabilized them. Liz and Janice do a pilot too with a drug court where they found a lot of the women are using meth to combat that neurofatigue. So people are understanding that something's not right, they just don't have the answers. Prisons, we aren't funded, we don't do this as part of our Mercy Care, but we do at some point hope to get to where people throughout the sequential intercept model can be more successful with a brain injury, all the way from crisis to probation. Here's some statistics about TBI and violence. And I think the #1 risk factor for a woman ending up incarcerated is that what they found is that she has been in a violent family or interpersonal violence, domestic violence situation. So definitely there's a lot of work to be done there. We won't go into any of the screenings, just other possible ways to assess that someone has had a brain injury: special education history, scars from brain injury, missing teeth, meaning there's been trauma about the head. Liz mentioned suicide. If someone is threatening suicide or multiple suicide attempts. And just a reminder that we are here to be a partner. If you'd like to partner with us for referrals, we do have support groups. Liz runs our family support group. Janice has the Ladies She Shed, which is hugely popular and virtual. We do a lot of things with artwork, conferences, free conferences, working with professionals. And also we have a utility fund. Don't ask me for any money today. It's all we just kept a bunch of people housed and their cell phones on, and we also have transportation funds as well if someone needs services. And just real quick, we'll ask everyone to end with a nice little laughter break at some point today. Try this out. Your brain doesn't know the difference between real laughter and fake laughter. So it wouldn't know if I told you the greatest joke ever, which I can never remember the punchline to. But at some point today, this is an Ann Zaccardi thing. Remember, she had that TED Talk. Pretend like you're pouring water back and forth 5 times and laugh really loud each time for 5 times. It will trigger something in your brain that will be very joyful. So any questions or anything as we wrap up?
Just as a reminder, for any questions, if you could just put it into the chat box to all panelists. And then you also have the option for the Q&A that is located to the right of your screen.
Thank you so much, Carrie, Liz, and Janice, for your amazing presentation and discussion. As Aisha mentioned, I'm going to go ahead and I'm going to share my screen again. This is a chance for you to ask any questions.
There does look like to be a question from Brittany Gooch. Do you all have speakers that go to organizations that speak on TBI?
We do if there's a partnership. So we would like to know, like, what is your end goal? Is it just someone to understand someone's lived experience, or are you going to start screening? So we have to be careful. Our clients we work with for weeks and weeks and weeks and months at a time. I think during COVID, we were spending an average of $2,000 per client just on different things that they needed to be successful. So we are careful, but yeah, we do have various speakers that go out.
There looks like to be a question from Shayla Clogg. I may have missed this. How do you refer a young adult to you?
Sure. So for that, you can reach out to our info@bias.org. We would like to know if this is just like a one-off referral, if you have a family member or if you're going to be doing a large number of referrals from your organization, we do want to work together, again, so that Liz and Janice can get a handle around, is this, what goals are they going to be referred for? How are you identifying people with brain injury? But if you do have, just a one-off or someone with maybe a family member, this comes up a lot. We all start thinking about someone that's caring for someone with a stroke. And this is important too. If sometimes you have someone who is going through their own SUD and they have a child or they have a parent that they care for that has a brain injury, that's also very, very common for us. But yeah, if you're going to be doing a large number of organizational referrals, we really need to talk about capacity, make sure that we have the right cultural competency to help your clients and what they're going through. We'd love to have a larger conversation. Someone says this is a lot of information. I need time to absorb. I get it.
There looks like to be another question. Who should we contact for partnerships?
You can contact that info and we'll talk about it. I see someone says that they're using kind of that visual. Someone has a scar on the back of their head, behavior has changed. Should we have a neuropsych evaluation completed? I think that's a larger conversation with a certified brain injury specialist that you really unpack. So Janice briefly touched on that there is screening tools, like, have you ever hit your head? Have you been to the emergency room? So that just tells you the lifetime history, which is cool. But then there's also a whole other component that tells you about how does the brain injury play out in your life. I've had a couple of concussions. I'm housed. I maintain a job. So there's two parts to that. How's it playing out in your life where you might need support? And is there a lifetime history? So there's a lot I wish it was as easy, again, as you have a cast, you're getting it off next Tuesday, tell your softball team you'll be back on Saturday. It's a bit more than that. There's also insurance, and access, and there's kind of also it's not a joke, but it's like, okay, what shows up on a scan? There's all kinds of questions that really, even if you're just going to the doctor for a concussion, we tell people, call our team, because we have a checklist where you can really think about how this possible brain injury is impacting your life. Janice or Liz, anything to add on the neuropsych?
Will people learn more about deficits, how to screen for deficits and accommodations at our peer support training that we have come up?
You will. So we want to know more about like how the screening is being used. So absolutely, you'll learn more about how behaviors can play out that disrupt and how to work with those from a peer support and advocate.
When is that again? The peer support thing?
20
It's
seconds.
next Tuesday, and the link is in the chat.
Okay, I'll repost it in case it got up there.
And Janice, there looks like to be a question for you. What is Ladies She Shed, please?
I saw that question. It's a support group that I helped develop for all of Arizona. Women that have been affected by or that have brain injury can be a part. It's a safe space so that women can get together once a month and discuss what's going on with them in their life. We highlight speakers where they tell about their journey from their brain injury and to where they are now. It's facilitated by a licensed clinical social worker, and I co-facilitate along with 2 other staff members. And it's a lot of fun. We've had a lot of attendance and a lot of participation and interaction. And if you want more information on that, I put my email address in the chat.
There looks to be another question. On the question for the psychoneurological evaluation, where does one start to get availability to this? Do they go to their PCP, or do they have a neurological evaluation from there?
Well, first of all, I would say reach out to our resource facilitation team with your questions, and the neurological evaluation needs to be referred from their primary care physician.
It helps too if we're connected too, because then we can do a follow-up and see how it went. Definitely anyone can look at different resources, and we do have a neuro database that we're redoing right now during COVID that's usually live on our website that has certain providers that understand brain injury, but things can get complicated. We had a gentleman, he tells this story for us. He was a professor in Prescott. He fell, waited months to get into for his evaluation. He has actually accidentally made an appointment with a neurosurgeon. So he had to start the wait time all over again. So it really helps to understand what your goal is. Is there going to be a possible lawsuit? Is this an older injury? We're now seeing providers that only see like sports concussions. There's really a lot to unpack